Welcome to the Practicing Clinicians Exchange podcast. This podcast series was developed from a live PCE conference focused on gastrointestinal and genitourinary cancers, including gastric cancer, colorectal cancer, hepatocellular carcinoma, bladder cancer, and prostate cancer. In each episode, you will hear the latest evidence and expert recommendations for the care of patients with a specified malignancy. In this podcast series, each of these topics will be discussed in 2 podcast episodes covering didactic presentation of the available evidence, relevant case discussions to illustrate clinical implementation strategies, and the audience Q&A session. Be sure to listen to the 2 podcast episodes for each topic in sequential order, as they may include examination of continuing case studies with patients progressing through different stages of their care. To claim your credit, please visit pce.is/GIGU.
Our learning objectives are to implement recommended testing for mutations and biomarkers that impact metastatic colorectal cancer, plan strategies for incorporating novel agents into the treatment of patients, and apply recommended strategies to identify and manage toxicities of novel agents for metastatic colorectal cancer.
In 2021, the estimated new cases for colorectal cancer were nearly 150,000, and there was going to be an estimated 53,000 deaths from colorectal cancer. We know that colorectal cancer is the 4th most frequently diagnosed cancer in the United States and the 2nd leading cause of cancer death. Fortunately, over the past couple decades, 2-year survival for metastatic colorectal cancer has improved from 21 to 31%, but obviously we still have more work to do to improve on this. The overall incidence or mortality have decreased, but this is mainly for patients greater than 50 years of age. For some reason, still unclear, for patients younger than 50 years of age, we've seen an increase in the incidence by 2.2% annually from 2012 to 2016. And we've also seen an increase in mortality by 1.3% annually from 2004 to 2017. We also know that the incidence rates for colon and rectal cancers is expected to increase markedly for patients aged 20 to 34 years by 2030. This has led to the U.S. Preventative Service Task Force updating screening recommendations to start screening patients for colorectal cancer at age 45.
Sarah is 46 years old and works full-time as an office manager and is married with 2 daughters younger than 12 years old. Her family history reveals her father was diagnosed with colon cancer at age 63, and her paternal grandmother died of endometrial cancer at age 52. She reported experiencing intermittent rectal bleeding for the past 3 months, and a recent chest X-ray revealed the presence of several lesions on her lungs. How would you work this patient up?
The recommended initial workup for colorectal cancer typically begins with a screening colonoscopy. We include a complete blood count, a chemistry profile, a CEA level, CT scans of the chest, abdomen, and pelvis, and if there is any lesions in the liver or lungs or other metastatic sites, we do recommend a biopsy of these metastatic sites. And then we also recommend molecular biomarker testing for each new patient. So the first biomarker that we want to discuss is microsatellite instability, otherwise known as deficient mismatch repair. And either test is recommended universally for every newly diagnosed colorectal cancer case. Now, I often get asked, what are microsatellites? Microsatellites are actually repetitive DNA sequences that are distributed throughout the genome in both coding and non-coding regions. So examples of a microsatellite is you might have one nucleotide repeat over and over, such as A. Or you may have 2 nucleotides repeat, such as GT, or 3 nucleotides repeat, such as ATG. And this repeats for a certain period of time. However, any changes in the number of nucleotide repeats within these microsatellites is called microsatellite instability. Now, there are two ways that we can test for microsatellite instability. We can look directly at the DNA sequences, usually either through PCR testing, just polymerase chain reaction, or comprehensive genomic sequencing, otherwise known as next generation sequencing, which interrogates a number of genes. Either one of these can provide a good assessment on the microsatellite status of a colorectal cancer. The other way to test for microsatellite instability or deficient mismatch repair is to actually do immunohistochemistry on the tumor tissue specifically to look for what we call deficient mismatch repair proteins. These are proteins that normally repair DNA replication errors, and we can test for these directly on the biopsy tissue. Now, these two tests are complementary of each other, and I will explain why that is. So when we think about microsatellite instability, looking directly at the DNA, this includes either looking for error in the DNA replication process that leads to slippage of a DNA polymerase either on a parental strand or on a daughter strand. So for instance, instead of having 3 A's directly, there could be 2 A's and then a little side loop of one of the A's. Otherwise, we can look for either deletion or gain of one of these base pairs. And again, these changes are what leads to microsatellite instability. Now, normally these changes would be repaired by DNA repair proteins. There are 4 major proteins that we test for in colorectal cancer. MLH1 and PMS2, they recognize base sequencing error and initiate the repair process. MSH2 and MSH6 acts as an endonuclease in DNA repair process. So if either one of these 4 proteins are missing, this leads to deletions or insertions in the microsatellites that are not repaired. And this leads to microsatellite instability. Therefore, when you see a pathology report, you may see either microsatellite instability or deficient mismatch repair. They essentially mean similar things. It's just that we are testing to look for the same process in different ways. The deficient mismatch repair, again, is tested by immunohistochemistry, looking for those missing enzymes directly on the tissue. Whereas the microsatellite instability looks specifically at the DNA with either PCR or NGS. We recommend that every patient be tested for either microsatellite instability or deficient mismatch repair in all newly diagnosed colorectal cancers. This is because it may identify patients that have Lynch syndrome, and it may identify a potential treatment option for these patients. So most of either microsatellite instability or deficient mismatch repair tumors are a result of what we call a sporadic mutation that just happened by chance in one or more of the genes encoding for this mismatch repair proteins. But there is a small percentage of patients with colorectal cancer that actually have a germline mutation, meaning they were born with a mutation that leads to deficient mismatch repair and therefore microsatellite instability. Now, this syndrome is known as Lynch syndrome or hereditary non-polyposis colon cancer, and it is directly inherited from a parent. And it is associated with a range of cancers. A lot of them are GI cancers, such as colon and gastric cancer, but other cancers, such as endometrial cancer, can be seen. And then the microsatellite instability or mismatch repair tumor status in the absence of a BRAF mutation, that is consistent with Lynch syndrome. But again, just because patients test positively for this doesn't mean they have Lynch syndrome. And in that case, when we see microsatellite instability or deficient mismatch repair, we need to refer those patients for genetic counseling to assess for family history and see if they would require to undergo further genetic testing. Now, if microsatellite instability or deficient mismatch repair occurs at the same time as a BRAF mutation, that is almost certainly a sporadic mutation, and we do not need to refer those patients further. Now, we know that patients with microsatellite instability or deficient mismatch repair have a better prognosis. And this has to do with the fact that the microsatellite repeats are actually mutagenic and they draw in the immune system. And therefore, even prior to immunotherapies being developed, those that had resected cancers with microsatellite instability, their immune system was involved and led to an improved prognosis. Now, since we have the immune checkpoint inhibitors available for treating these patients, that has certainly conferred a better prognosis because the microsatellite instability is predictive of response to our immunotherapies. Now, other biomarkers that are very important to test in colorectal cancer, one of them would be the RAS mutations. So there's KRAS and NRAS. And if patients have a mutation in either KRAS or NRAS, they are not eligible for our EGFR or epidermal growth factor receptor antibodies, such as either cetuximab or panitumumab. This testing needs to occur either in a next generation sequencing panel, as we mentioned before, or some institutions have specific gene testing for these mutations. Another important mutation to test for is BRAF. Now, BRAF mutations are associated with a poorer prognosis because they've been traditionally not as responsive for as long to systemic therapies. But now we also have a treatment that predicts or that BRAF mutations are predictive of response. And this is a BRAF targeted therapy, which we'll get into in the next couple minutes. And then the HER2 is also another important biomarker for metastatic colorectal cancer. Now, we're used to thinking about HER2 in breast cancers, but we know that there's a small percentage of colorectal cancer that also overexpresses HER2. And this can be identified either through next generation sequencing or FISH, which shows amplification of HER2, otherwise known as ERBB2 on these NGS panels, or immunohistochemistry can also be done looking for HER2 overexpression. Another biomarker that's very important to test for is something we call NTRK or NTRK. And this is also a very small percentage of colorectal cancers that have what we call an NTRK gene fusion. But if they do, they are candidates for NTRK fusion inhibitors, such as entrectinib and larotrectinib. These fusions can be found on next generation sequencing again, but they can also be detected by immunohistochemistry and FISH if that is validated at a particular institution. People also ask me about tumor mutational burden and whether we should be routinely testing this for colorectal cancer. And the answer is this typically is resulted on any next generation sequencing panel. So you'll get that if you send the tumor testing for that full genetic testing. And the immunotherapies are approved for patients with what we call high TMB across multiple tumor types. But unfortunately, for patients with high TMB colorectal cancer, we're not quite seeing the same robust responses we're seeing in other cancers. And so the jury is still out on whether this is a good marker or not for response in colorectal cancer. Similarly, for PD-1 and PD-L1 testing, this is not part of the NCCN guidelines because these biomarkers are not good predictors of response to immunotherapy from colorectal cancer. So we recommend gene-based testing in all metastatic colorectal cancer. Need to evaluate for, at a minimum, KRAS mutations, NRAS mutations, and BRAF mutations, as well as for the NTRK gene fusions. We also think it's very important to test for HER2 status, and this, again, can be done with next-generation sequencing, immunohistochemistry, or FISH studies. We talked about the frequencies of a lot of these gene alterations in metastatic colorectal cancer can be quite low. So for instance, BRAF mutations occur in about 7.5% of colorectal cancer. HER2 amplifications occurs in about 3%. Microsatellite instability occurs in about 5% of metastatic colorectal cancer. NTRK fusions occur in less than 1%. And KRAS mutations occur in approximately 40%, with other RAS mutations occurring in another approximately 7 to 10% of patients. So very important, even though they are low rates, they can identify potential treatment options for patients. And remember, 5% of 150,000 new cases amounts to quite a lot of cases.
Right, we'll continue with Sarah. Assessment reveals a metastatic colorectal cancer characterized by a primary right-sided colon cancer with synchronous metastasis to the liver and lungs. Sarah, unfortunately, is not a candidate for surgery, and no other comorbidities have been identified. Biopsy of the primary tumor and liver metastasis shows adenocarcinoma and a high level of immune infiltrate. Molecular testing by next-gen sequencing shows negative for KRAS, NRAS, BRAF, HER2, and NTRK. The cancer is, however, MSI high with mismatch repair deficiency. Additional assessment and testing is performed by a genetic counselor reveals that Sarah has Lynch syndrome. She expressed concern regarding the potential impact of chemotherapy on her ability to keep working.
So our patient, Sarah, was diagnosed with Lynch syndrome. And although the presence of microsatellite instability in Lynch syndrome confers eligibility to receive immunotherapy, this diagnosis of Lynch syndrome does not restrict other treatment selection for metastatic colorectal cancer. We do feel referral to genetic counseling is very essential for patients who did screen positive for microsatellite instability to confirm whether they do have Lynch syndrome or not with germline testing. This is really important for the patient's relatives and particularly their children. And then genetic counseling can also provide screening recommendations for the patient's family members as well.
Let's look at sidedness. Dr. Eng, could you take us through this?
Thank you so much. Yes, we'll talk about sidedness because this has an impact on our decision-making process. So we understand that primary tumor sidedness is a prognostic factor. It's independent of molecular features and tumor burden. And left-sided tumors are significantly associated with improved overall survival, regardless of the biologic treatment provided. So it appears to be that FOLFIRI plus cetuximab was associated with longer overall survival than FOLFIRI plus bevacizumab based upon some prior studies. And keeping in mind, right-sided tumors, once again, are more common in patients with Lynch syndrome, such as our patient here. Unless MSI high, right-sided tumors are overall associated with a poorer prognosis. They're more likely to have a RAS mutation or BRAF mutation. And optimal treatment is yet to be defined. Patients with right-sided tumors fare worse with anti-EGFR therapy in combination with chemotherapy. NCCN recommends FOLFIRI plus cetuximab or panitumumab as initial intensive therapy only for patients with left-sided tumors without RAS or BRAF mutations. Once again, sidedness is very important in treatment-naive stage 4 patients. What other factors do we want to take into account when we're thinking about treatment choices for our patient population? Basically, once again, we want to look to make sure if there's been any prior therapy. We want to look at the ECOG performance status. We want to take into account their comorbidities and only their age, I would say, if there's significant comorbidities that you're concerned about. So overall picture. We also like to take into account tumor characteristics, Once again, looking at sidedness, potential chance of resectability, and the overall degree of tumor burden. That may also help you make a decision about pursuing a more aggressive approach rather than just standard treatment. Once again, we encourage looking at molecular characteristics early on: RAS, BRAF, MSI status, HER2. TMB could have a potential impact on your decision-making process, although once again, it's not approved in NCCN guidelines for colorectal cancer, and then the NTRK fusion. For patient-centered issues, we want to think about quality of life for our patients, treatment toxicities, adherence with the recommendation of the chemotherapy, and psychosocial factors, especially when you're talking about a young patient such as this patient here. So our take-home point here is consider tumor characteristics, prior treatments, consideration of response if this is potential surgically resectable patient, and the patient's current status and goals of therapy. So I think that's extremely important to discuss with the patient early on. Is the goal for palliation and to improve their overall survival, or is their goal for potential resectability? So those factors should be taken into account early on, and always with multidisciplinary management if appropriate. So looking at the initial lines of therapy when considering intensive treatment, meaning that we want to also include systemic therapy, we're looking at all patients here. So on the left, most patients will proceed with chemotherapy plus or minus bevacizumab if appropriate. And the chemotherapy backbone, as many of you know, could be FOLFOX or CAPOX, if it's appropriate to use capecitabine in combination, FOLFIRI, and then FOLFOXIRI if you're looking for a more aggressive treatment regimen. If the patient is wild-type RAS and BRAF wild-type, you may consider anti-EGFR therapy, but once again, it's also very reasonable to utilize bevacizumab in that setting and then reserve anti-EGFR therapy in subsequent lines of treatment. And then obviously the anti-EGFR regimen drugs that we have available to us include cetuximab and panitumumab, keeping in mind that cetuximab is chimeric and ideally should not be utilized as your first choice just due to a potential allergic hypersensitivity reaction if you're in the southern Bible Belt region. So keep that in mind. And for patients that are MSI high or deficient mismatch repair patients, as mentioned here with our patient that we're discussing, pembrolizumab would be the preferred option, and we'll discuss some data there. The other options are potentially nivolumab plus or minus ipilimumab. Now, for some patients that are not appropriate for intensive therapy, you may want to consider just capecitabine or IV 5FU and leucovorin, if you utilize leucovorin in your practice group, plus or minus bevacizumab. And once again, anti-EGFR therapy as a single agent is reasonable if the patient is RAS wild type and BRAF wild type. For HER2 positive patients and those that are not appropriate for intensive therapy, you can utilize lapatinib or pertuzumab, and then deruxtecan is an option for patients, which is an antibody drug conjugate. And then, of course, as mentioned earlier, IO therapy or immune checkpoint inhibition is recommended for MSI high or deficient mismatch repair patients. So going back to what is considered the standard of care, we mentioned for this patient that we would recommend pembrolizumab as our first choice. And that is based upon Keynote 177. Keynote 177 was a randomized phase 3 study comparing to the standard of care. And they had dual primary endpoints of overall survival and progression-free survival. The standard of care, it was recommended to be utilized a platinum-based treatment. And when you're looking at the overall outcomes, the median progression-free survival for pembrolizumab versus standard chemotherapy was 16.5 months versus 8.2 months. The hazard ratio here was 0.59. And the 12-month progression-free survival was also superior at 55% versus 38%. The 36-month progression-free survival was 42% versus 11%. And the median overall survival had not yet been reached versus the control arm of 36.7 months with a hazard ratio of 0.74. However, keeping in mind it has dual primary endpoints and one being progression-free survival, it did allow crossover if you were in the control arm. And please note, obviously, there were less potential toxicities if you utilized single-agent pembrolizumab versus standard chemotherapy. So here is the KM curves for first-line pembrolizumab versus chemotherapy. As mentioned earlier, the progression-free survival was superior for the use of pembrolizumab versus standard chemotherapy in treatment-naive patients of 16.5 months versus 8.2 months. Now, keep in mind, these are dual primary endpoints, and it was noted that the KM curves crossed in about a third of patients. The exact etiology of that has not yet been well defined. And then in overall survival, once again, it had not yet been reached in regards to the pembrolizumab arm. Now, what about, as mentioned earlier, the consideration of nivolumab plus or minus ipilimumab? This is based upon a single-arm phase 2 study of Checkmate 142. And this data was actually very, very interesting. After median follow-up of 29 months, once again, MSI high treatment-naive patients, the overall response rate was 69%, so quite impressive. And the 24-month progression-free survival was 74%, and the 24-month overall survival was 79%. The primary endpoint here was overall response rate. But once again, single-arm phase 2 data differs from the Keynote 177 study, but very provocative data. What about FDA indications based upon what we know on the information available to us? So for immune checkpoint inhibition in MSI high or deficient mismatch repair patients, once again, pembrolizumab is approved as initial therapy. It can also be utilized in previously treated patients and also can be utilized based upon high TMB. Now, nivolumab is currently only approved in previously treated patients, and nivolumab and ipilimumab, once again, is very provocative regarding this data, but it's currently only approved in previously treated patients. And then there's dostarlimab, which is the most recent PD-1 inhibitor from the Garnet trial, which has been recently approved for previously treated patients as well. So the take-home point is be aware of the recommended treatment settings and associated molecular marker use of immune checkpoint inhibition. So Stephanie, I think we'll take it, you'll lead the way on this.
Thank you. So you prescribe Sarah pembrolizumab and tell her that she can receive the treatment infusion either 200 milligrams every 3 weeks or 400 milligrams every 6 weeks. You both think less frequent visits to the infusion center will be helpful during the ongoing pandemic as she begins treatment with 400 milligrams every 6 weeks. After 3 cycles of pembrolizumab, a follow-up CT scan revealed a partial response. However, Sarah reported moderate fatigue at the 18-week visit. Routine thyroid function testing revealed an increase in TSH level from a previous value in the normal range at 12 weeks to 12 at 18 weeks, consistent with new onset of grade 2 primary hypothyroidism. Can you talk a little bit more, Dr. Eng, about these IRAEs?
Happy to discuss this. Thank you so much, Stephanie. So I think this is really important to take into account because people tend to presume that immune checkpoint inhibition or immunotherapy has no toxicities, and that's not the case. It just has different toxicities. So currently, there's no way to predict who will develop any of these adverse events. Once again, keeping in mind it differs from other adverse events seen with other therapies. The onset can occur 2 to 3 months after starting therapy, but it can also occur many months afterwards. It's very important to obviously reach out to your oncology team if any symptoms develop, such as severe fatigue, headache, cough, abdominal discomfort, etc. If any of these are suspected and associated, you believe, with immune therapy, the patient needs additional workup. And that's when we may also need the assistance of some of our colleagues. So frequent AEs that we commonly see predominantly involve the GI tract, as well as skin toxicities and the lungs. In regards to the GI tract, it can occur anywhere in the GI tract, and the clinical presentation is very non-specific, but could be rather urgent as well. 5 to 10% of patients also may develop an autoimmune hepatotoxicity, and it's really important to follow their LFTs. In regards to skin toxicities, there are rare instances of erythema multiforme, or bullous dermatosis. If mild topical treatment and sun avoidance is recommended, and then obviously quality of life should be considered if there's any potential impact with holding or initiating steroid use. In regards to lung toxicities, if pneumonitis is suspected, it's extremely important to get a chest x-ray and follow the patients with a pulse ox. Grade 1 toxicity may require withholding treatment if the x-ray shows new changes, and systemic prednisone is required for grade 2 toxicity. So here's some general guidelines. Once again, grade 1 is very mild. You can continue your therapy. But if you've developed any grade 2 or mild to moderate toxicities, you really have to address the patient's symptoms and consider withholding treatment until it's resolved to less than or equal to grade 1. At this point, you may want to consider low-dose prednisone and, if necessary, involve your colleagues as needed for consultation. Obviously, for grade 3 or 4 toxicity, that's a different story. We recommend holding treatment and initiating high-dose prednisone. For grade 4, permanently discontinue therapy may need to be considered. And once again, we highly encourage, if you have a severe toxicity, that you involve your colleagues. And so once again, it's very important to follow these patients closely. In regards to hypothyroidism, which can be a common issue for patients, I would say this is probably the most common toxicity that I have seen. Once again, if it's just grade 1, no worries. If it's grade 2 and the patient is having moderate symptoms, you may want to consider holding therapy until the symptoms resolve and prescribing thyroid hormone supplementation. And at times, just to make it easier for the patients to be followed, I would also recommend an endocrinology consultation. However, for grade 3, once again, hold your immunotherapy until the symptoms have resolved. And once again, thyroid hormone replacement therapy would be required, and then consider admission if necessary. Once again, really discussing, making sure you're having that open communication with your patient about potential toxicities. Going back to all the various immune checkpoint inhibitors that are available, here is a list for pembrolizumab, nivolumab, ipilimumab, and dostarlimab, and these are the most common toxicities that have been reported based upon previous studies that have been published or presented. So immunotherapy, once again, is associated with unique adverse reactions requiring special management. So it is not benign in regards to the treatment with immune checkpoint inhibition. It does have potential toxicities. Once again, could be the skin, GI tract, and the lungs. Please follow the TFTs. We tend to follow patients. We would recommend it every 4 to 6 weeks or every 3 months. Would be very reasonable. Early detection is extremely important. And once again, if you have any significant toxicities you are concerned about, consider initiating steroid therapy. And once again, communicate with your patients and educate them about potential toxicities so they are aware to reach out to you and your team. So the take-home point, once again, be alert to the type and potential of potential AEs in patients receiving immunotherapy and educate patients about their symptoms. So Stephanie, I'll leave it up to you now.
Thank you. Following initiation of thyroid hormone supplementation, symptoms of hypothyroidism resolve and routine monitoring reveals normal TSH level. 1 dose of pembrolizumab is skipped following initiation of thyroid hormone supplementation, and the latter is continued indefinitely. Unfortunately, at 18 months following initial administration of pembrolizumab, Sarah experiences disease progression.
Thank you for listening to the Practicing Clinicians Exchange podcast. To claim your credit, please visit pce.is/GIGU. And while you're there, don't forget to check out our website for more complimentary oncology CE/CME activities.